Welcome to this deep dive. It's designed to help you conquer the FRCS Plastic Exam's eyelid anatomy section. We'll be dissecting high-yield concepts and those intricate details, the ones that could really make or break your performance.
Yeah, it's true. A solid grasp of eyelid anatomy. That's essential for any aspiring plastic surgeon. And not just for the exam, for your future practice as well.
Okay, let's unpack the procedure itself, blepharoplasty. You'll need to be able to define it, understand its prevalence, and recognize the demographics most likely to seek it out.
So blepharoplasty is the surgical removal of excess eyelid skin, and sometimes fat. It's incredibly popular, especially among women in their 40s and 50s, seeking both functional and aesthetic improvement.
Now, the eyelid structure, this is where it gets really interesting. Remember, it's classically divided into three lamella.
The anterior lamella, that comprises the skin and the orbicularis oculi muscle, while the posterior lamella is composed of the tarsus and the conjunctiva. The middle lamella is formed by the orbital septum and the intraorbital fat.
Let's break those components down further. First up, the orbicularis oculi muscle. Not only do you need to know its three portions, orbital, palpebral, and lacrimal, but also their precise locations and functions.
Okay, so the orbital portion, that's the outermost layer, responsible for forceful eyelid closure. And it's under voluntary control. The palpebral portion contributes to both voluntary and involuntary blinking. And lastly, the lacrimal portion is responsible for involuntary blinking, and it aids in tear drainage.
And don't forget about the innervation, primarily by the zygomatic branch of the facial nerve, with some medial innervation from the buccal branch.
Absolutely. Now, the tarsal plates, they form the backbone of the eyelids. They provide structural support and shape. Pay close attention to their dimensions. The upper tarsal plate, that's about 30 millimeters horizontally and 10 millimeters vertically, while the lower tarsal plate is smaller, around 4 to 10 millimeters wide.
You want to remember those numbers
Yeah.
for the exam. And speaking of crucial structures, let's not forget the lateral canthus.
The lateral canthus is where the eyelids meet, laterally, and it plays a critical role in lower lid fixation. It's formed by the intricate lateral retinaculum, which consists of fibrous connections between the tarsal plates and Whitnall's tubercle on the lateral orbital rim.
And while we're on the topic of attachments, you'll need to be able to differentiate between the superficial and deep canthal tendons.
Okay, the superficial canthal tendon connects with the orbital septum and attaches to the lateral orbital rim. The deep canthal tendon, also known as the tarsoligamentous band, runs deeper, inserting onto Whitnall's tubercle.
Now let's dive into the fat pads.
Sure.
First, the preceptal fat, lying between the septum and orbicularis muscle.
Yeah.
This is where understanding the difference between ROF and SOF comes in.
In the upper lid, it's called ROOF, retroorbicularis oculi fat. And in the lower lid, it's SOO, suborbicularis oculi fat. Both contribute significantly to eyelid hooding and puffiness, which are key considerations for blepharoplasty.
Next up, a structure often tested on the FRCS plastic exam, the orbital septum. You'll need to know its origin, extension in both upper and lower lids, and the consequences of its attenuation.
The orbital septum, that's an extension of the periosteum lining the bony orbit. It originates from the arcus marginalis, a thickened band of periosteum. In the upper lid, the septum extends from the superior orbital rim to the levator aponeurosis, approximately 10 to 15 millimeters above the tarsal border.
In the lower lid, it attaches to the capsulopalpebral fascia, about 5 millimeters below the lower tarsal border. Remember weakening of the septum. That can lead to the herniation of orbital fat.
Precisely. Herniated fat. It creates that bulging appearance we often see in patients seeking blepharoplasty.
Now, shifting our focus to the muscles responsible for eyelid movement. First, the levator palpebrae superioris. You'll need to know its origin, insertion, innervation, and action.
The levator palpebrae originates from the lesser wing of the sphenoid bone and inserts onto the dermis and superior edge of the upper tarsus. It's innervated by the oculomotor nerve, cranial nerve 3, and is the primary elevator of the upper eyelid, providing about 10 to 15 millimeters of lid elevation.
And don't forget Whitnall's ligament, this fibrous structure. It acts as a pulley. It changes the direction of the levator muscle's pull, and also plays a role in the formation of the supratarsal crease.
You'll also need to know about Miller's muscle, a smooth muscle that contributes to about 2 to 3 millimeters of upper lid lift. It's under sympathetic control, which is a key distinction from the levator palpebrae.
In the lower lid, we have the capsulopalpebral fascia, analogous to the upper eyelid's levator system. Make sure you can compare and contrast these two structures.
The capsulopalpebral fascia originates from the inferior oblique muscle fascia and inserts onto the orbital septum, about 5 millimeters below the tarsus. It contributes to lower lid movement. during downward gaze.
Now onto orbital fat. A key point here is that it has unique characteristics compared to fat in other parts of the body, which has surgical implications.
Orbital fat has smaller cells, it's more saturated, and is less metabolically active. This makes it less responsive to dietary changes, a fact that often surprises patients.
And of course, you need to be able to list the fat compartments in both the upper and lower eyelids.
In the upper eyelid, the medial and middle compartments are separated by the trochlea of the superior oblique muscle. In the lower eyelid, the inferior oblique muscle separates the medial and central compartments.
Don't forget about Eisler's fat pad. Located above the lateral canthus, it's a valuable landmark during canthoplasty and canthopexy procedures.
Absolutely. Now let's turn our attention to the lymphatic drainage of the eyelids, focusing on the lower eyelid.
The lower eyelid has two lymphatic drainage systems, superficial and deep. This is clinically relevant because it helps us anticipate the spread of infection.
The superficial system drains the medial and lateral campal tendons and runs within the subcutaneous fat. It eventually drains into the submandibular, or preauricular lymph nodes. The deep system drains the conjunctiva, courses through the tarsus and SOF, and ultimately drains into the parotid lymph nodes.
Next, let's move on to the midface and the lid-cheek junction. This area has significant aesthetic implications, and you'll need to be familiar with its key structures.
The prezygomatic space, located below the orbicularis oculi muscle, is a key anatomical landmark. Its roof is formed by the SOF. While the floor is composed of properous steel fat, the orbitomolar ligament forms its upper boundary, and the zygomatic-cocutaneous ligaments define its lower boundary.
Another structure you'll need to know is the tear trough, that depression under the eyes.
The tear trough is formed by the orbitomolar ligament, the levator labii superioris muscle, and the levator alecanasi muscle. Its medial portion is formed by the tear trough ligament.
And let's not forget the molar fat pad, also known as the infraorbital fat. It's important to understand its relationship to the surrounding structures, particularly the zygomatic ligaments.
This area can be tricky, so make sure you spend some time studying the interplay of these structures. It's crucial for addressing the aging face, especially in procedures like mid-face lifts.
Moving on to the lacrimal apparatus. You'll need to be able to describe the lacrimal gland's location and its division into palpebral and orbital portions.
The lacrimal gland, responsible for tear production, is located beneath and behind the lateral portion of the superior orbital rim. It's divided into two portions, by the levator aponeurosis, the palpebral portion, and the orbital portion.
You'll also need to be able to explain the lacrimal drainage system, including its active pump mechanism.
The lacrimal drainage system starts with the puncta, those tiny openings on the medial aspect of the eyelids. From there, tears drain into the canaliculi, then the lacrimal sac, and finally into the nasolacrimal duct, which empties into the nasal cavity.
Remember, this system relies on an active pump mechanism, driven by blinking, to effectively drain tears.
That's right. Now let's discuss the conjunctiva, the clear membrane lining the inner surface of the eyelids and covering the sclera.
The conjunctiva is essential for maintaining ocular surface health. You'll need to know its location and its role in tear film production.
The palpebral conjunctiva, lining the eyelid, adheres tightly to the tarsal plate and lid retractors. It transitions into the bulbar conjunctiva at the fornix. The conjunctiva plays a crucial role in tear film production through small accessory lacrimal glands within it.
Speaking of tears, remember they have multiple functions, not just lubrication.
Tears also possess antibacterial properties, provide oxygen to the corneal epithelium, and maintain a smooth refractive surface for clear vision.
And you'll need to know the three layers of the tear film.
The outermost layer is the lipid layer, produced by the meibomian glands and the glands of Zeiss and Moll. The middle aqueous layer is produced by the main lacrimal gland and the glands of Wolfram and Krauss, and the innermost mucoid layer, produced by goblet cells in the conjunctiva, ensures tear film adherence.
Make sure you can differentiate between basic tear secretion, which is continuous, and reflex tearing, triggered by irritants or emotions.
Basic secretion comes primarily from the accessory lacrimal glands, goblet cells, and meibomian glands, while reflex tearing is driven by the main lacrimal gland under parasympathetic control.
Now let's shift gears to eyelid measurements and aesthetics. You know key areas for both the exam and your practice.
Indeed. You'll need to be familiar with typical measurements for various eyelid features. For instance, the palpebral fissure, that usually measures about 12 to 14 millimeters vertically and 28 to 30 millimeters horizontally.
You'll also need to know the ideal positions for the upper and lower eyelid margins.
the upper eyelid margin, should rest at the level of the upper limbus, its highest point slightly medial to the pupil. The lower eyelid sits at the lower limbus, its lowest point slightly temporal to the pupil.
And don't forget about pretarsal skin measurements. Visible pretarsal skin should be about 3 to 6 millimeters, and the distance from the lash line to the supratarsal crease, that's generally 8 to 10 millimeter.
As for the brow, in the mid-pupillary line, the distance from the anterior hairline to the brow is typically 5 to 6 centimeters, brow to orbital rim, about 1 centimeters, and brow to supratarsal crease, around 16 millimeters. The distance from the brow to the mid-pupil, that's usually around 2.5 centimeters.
Remember, these are just averages. Individual variations exist, and you'll need to consider those in your assessment.
Precisely. Achieving aesthetically pleasing eyelids, that goes beyond just measurements. It involves a harmonious balance of several features.
For example, a youthful appearance often includes a full superior orbital sulcus, the area just below the brow.
Aging, trauma, or previous upper blepharoplasty can lead to a hollowed appearance in this area, while excessive volume, that can appear unnatural and contribute to upper eyelid ptosis.
Another key feature is a well-defined supratarsal crease with adequate pretarsal show.
The supratarsal crease is formed by the insertion of the levator aponeurosis into the dermis above the tarsus. Ideally, there should be about 3 to 6 millimeters of pretarsal show, which refers to the visible portion of the eyelid between the lash line and the supratarsal crease.
Of course, the eyelids should also be in a proper position without any contosis or ectropion.
A subtle lower lid pretarsal bulge, created by the fullness of the pretarsal orbicularis oculi muscle, that's often considered attractive, and a smooth transition between the lower eyelid and cheek, the lid-cheek junction, that contributes to a youthful and refreshed appearance.
It's important to recognize that this area is prone to showing signs of aging.
Indeed. Excess skin, herniated orbital fat, descent of the Miller fat pad, a prominent nasarjugal groove, and visibility of the inferior orbital rim are all common signs of aging in the lid-cheek junction.
Now let's delve into Asian eyelid anatomy, which has distinct characteristics that set it apart from other ethnicities.
The most notable feature of the Asian upper eyelid is the absence, or a very short supratarsal crease. This is due to a combination of factors, including a shorter tarsus, descending preaponeurotic fat, and minimal to no connections between the levator aponeurosis and the upper lid dermis.
Externally, Asian eyelids typically present with an almond-shaped palpebral fissure, with varying degrees of upward slant, lascia pansis, where the eyelashes point downwards, and a medial epicanthal fold.
Understanding these unique anatomical features, that's essential when performing blepharoplasty on Asian patients, as the surgical techniques and goals may differ significantly.
Let's move on to common eyelid conditions and deformities that you'll likely encounter in your practice. You'll need to be able to define and differentiate between these conditions.
Dermatochalasis is a common age-related change, referring to excess eyelid skin, often resulting in a drooping or hooded appearance. Stetoblepharon occurs when excess orbital fat protrudes through a weakened septum, creating puffiness in the eyelids.
Blepharochalasis is a rarer condition involving thin and excessively loose upper and lower eyelid skin. It's typically caused by recurrent episodes of painless eyelid edema, often presenting before the age of 20.
Blepharoptosis, or drooping of the upper eyelid, results from dysfunction of the eyelid levator mechanism. This can be congenital or acquired.
Pseudoblepharoptosis mimics true passus, but it's caused by a drooping brow and excess brow skin, pushing the eyelid downwards. Callus adiposa involves extreme laxity of the canthal tendons and orbital septum, leading to significant drooping and sagging of the eyelids.
Accurately diagnosing these conditions is crucial for selecting the appropriate treatment strategy.
Now let's transition to the preoperative evaluation for blepharoplasty.
A thorough history and physical examination are paramount. Understanding the patient's expectations is critical. We need to determine whether their goals are primarily functional, aesthetic, or both.
It's also important to inquire about the patient's medical history.
We need to identify any coagulopathies, thyroid dysfunction, hypertension, or renal, or cardiac abnormalities that could predispose them to edema. It's also crucial to ask about any medications they're taking, particularly anticoagulants or antiplatelets, which may need to be adjusted before surgery.
Their ocular history is equally important.
We need to inquire about their vision, use of corrective lenses, history of trauma, glaucoma, allergies, excessive tearing, or dry eyes. A history of vision correction or refractive surgery is particularly important, as these procedures can predispose patients to dry eye symptoms, after blepharoplasty.
Now let's discuss the physical examination, starting with the forehead and brow.
When assessing the forehead, look for a prominent frontalis crease, which could indicate the patient is unconsciously using their frontalis muscle to compensate for brow ptosis.
To assess for brow ptosis, have the patient relax their forehead and close their eyes. Gently place your hand on their forehead to immobilize the frontalis muscle and ask them to open their eyes if the brow position is lower than when they were looking straight ahead. This indicates compensated brow ptosis.
Identifying compensated brow ptosis is essential because performing upper blepharoplasty alone could exacerbate the brow ptosis.
Glabular frown lines suggest overactivity of the corrugator muscles.
When examining the upper eyelid, assess for redundant skin, particularly lateral hooding.
Evaluate the position of the supratarsal fold, which should be about 7 to 11 millimeters from the lash line. A high supratarsal fold could suggest levator dehiscence.
Carefully inspect for fat herniation.
Assess for any soft tissue excess, which could include subcutaneous fat, perceptal fat, or lacrimal gland ptosis.
The eyelid position should be at the superior border of the limbus. Also, evaluate for canthal tilt.
Remember, if you suspect upper eyelid ptosis, especially if it's acquired, consider myasthenia gravis as a potential underlying cause. Now let's move on to the lower eyelid examination.
Begin by assessing for redundant skin, including both fine wrinkles and deeper rhytids. Next, evaluate tarsal laxity, which can contribute to lower eyelid malposition. You can use the pinch test.
Inspect for any skin pigmentation irregularities.
Examine for redundant or ptotic orbicularis oculi muscle, which can create festoons. Ask the patient to forcibly close their eyes, performing the squinch test.
A malar bag is often mistaken for a festoon. It's caused by lymphedema of the malar fat pad and typically appears as a bulge below the lower eyelid.
It's important to remember that festoons are a muscle problem, while malar bags are a lymphedema problem.
Next, assess for fat herniation in the 3 compartments of the lower eyelid: medial, central, and lateral.
Carefully evaluate the tear trough.
Finally, evaluate for scleral show. The lower eyelid should ideally be positioned up to 2 millimeters below the inferior limbus.
A comprehensive lower eyelid evaluation should also include Jelks' 7-step method.
Moving on to the ocular examination, it's important to document the best corrected visual acuity for each eye using a Snellen eye chart.
Assess Bell's phenomenon.
Evaluate for any signs of eyelid ptosis.
Lacrimal function testing is essential.
Schirmer's test assures both basic and reflex tear secretion.
Schirmer's test 2 measures basic tear secretion alone.
Now let's transition to surgical techniques, focusing on upper blepharoplasty first.
The primary goals of upper blepharoplasty are to create a well-defined supratarsal crease, expose smooth protarsal skin, and refine the volume of the supratarsal eyelid.
Marking for upper blepharoplasty is crucial for achieving symmetrical and aesthetically pleasing results.
The lower incision line is marked with the patient in an upright position, and the upper eyelid under closing tension. The mark is usually placed about 9 to 11 millimeters above the lash line.
The upper incision line is marked based on the amount and location of skin redundancy.
Once the markings are complete, the procedure begins with the excision of the excess skin.
The orbicularis oculi muscle can be open or partially excised, if desired. However, it's crucial to preserve the pretarsal orbicularis muscle.
Excising a portion of the orbicularis muscle can reduce upper eyelid bulk. However, preserving the muscle helps maintain upper eyelid fullness.
The orbital septum is then incised, taking care to avoid injury to the underlying levator palpebrae superioris muscle.
Redundant intraorbital fat can then be excised, if indicated. The medial fat compartment in the upper eyelid has more compact, dense fat lobules that are paler than the fat in the central compartment. It's also more vascular.
The middle and medial compartments contain more loosely organized yellow fat lobules. It's important to avoid over-resection of intraorbital fat.
The retroorbicularis oculi fat, ROOF, can also be excised if it's contributing to lateral fullness in the upper eyelid.
During upper blepharoplasty, it's essential to assess the position of the lacrimal gland. If it's ptotic, consider performing a glandulopexy.
If the patient has a prominent superolateral bony orbit, bony reduction can be considered.
The final step of upper blepharoplasty involves skin closure.
Tarsal fixation techniques are sometimes employed to create a higher and more defined supratarsal crease.
Tarsal fixation is often indicated in patients with Asian eyelids, those with a preoperative lid fold less than 4 to 7 millimeters from the lid margin, those undergoing secondary blepharoplasty, and men with brow ptosis.
There are several different tarsal fixation techniques.
Asian upper eyelid surgery aims to create a supratarsal crease that is more aesthetically pleasing in this specific population.
The ideal outcome is an open eye appearance. Both open and closed techniques involve suspending the levator and or tarsus to the dermis.
The closed technique uses two sutures to anchor the tarsus to the deep dermis. Now let's discuss lower blepharoplasty.
The objectives of lower blepharoplasty are to restore a youthful appearance, with the lower eyelid gently touching the inferior edge of the limbus and the lateral canthus elevated, about 1 to 2 millimeter above the medial canthus. Lower blepharoplasty also aims to recontour or remove redundant fat, tighten loose skin, and smooth the lid sheath junction.
There are three main approaches to the lower eyelid: skin flap, skin muscle flap, and transconjunctival.
The skin flap approach involves making a subciliary incision just below the eyelashes to create a skin flap over the perceptal orbicularis muscle.
The skin muscle flap approach also uses a subciliary incision, but involves creating a combined skin muscle flap.
The transconjunctival approach involves making an incision in the palpebral conjunctiva. There are two variations of the transconjunctival approach, perceptal and postseptal.
The postseptal approach involves making the incision just anterior to the fornix.
The perceptal approach involves making the incision approximately 2 millimeter below the lower border of the tarsus.
Fat resection can be performed through any of these approaches.
In addition to removing fat manipulation techniques can be employed to improve lower eyelid contour.
Loeb's procedure involves sliding the medial fat pad out of its compartment and into the tear trough.
The arcus marginalis release involves redraping the lower compartment fat over the inferior orbital rim.
Septal reset involves redraping the lower compartment fat over the rim, while also repositioning the orbital septum.
Fat augmentation can be used to smooth the lid cheek junction when performed in conjunction with transconjunctival blepharoplasty.
Addressing lower eyelid laxity is crucial for achieving optimal results in lower blepharoplasty.
Tarsal shortening procedures, such as the Kuntz-Semenowski procedure, involve removing a pentagonal wedge of tissue lateral to the lateral limbus to shorten the lower eyelid.
Lateral canthoplasty involves dividing the lateral canthus and repositioning the lower canthal tendon.
Canthopexy and retinacular suspension techniques involve tightening or repositioning the lateral canthus or lateral retinaculum.
Canthopexy provides mild lid tightening and canthal elevation.
In patients with prominent eyes, the canthopexy should be positioned slightly higher to prevent downward displacement of the lower eyelid and subsequent scleral show. Now, let's discuss some potential complications of blepharoplasty. Asymmetry is the most common complication. It occurs to some degree in many patients. It can involve differences in eyelid height or contour or the position of the supratarsal crease. In some cases, revision surgery might be necessary.
Retrobulbar hematoma. Although rare is a serious complication, that can occur after blepharoplasty, particularly after fat removal.
You need to be able to recognize the signs and symptoms of a retrobulbar hematoma, which include pain, proptosis, eyelid ecchymosis, decreased vision, limitations of extraocular movements, dilated pupils, scotomas, and increased intraocular pressure.
Management of a retrobulbar hematoma requires immediate action.
The patient's head should be elevated, and surgical incisions should be released to relieve pressure. Lateral cantholysis can further reduce orbital pressure. Intravenous medications might be necessary to control intraocular pressure. An immediate ophthalmologic consultation is essential.
Blindness is a devastating but extremely rare complication of blepharoplasty. It typically results from a retrobulbar hematoma that leads to central retinal artery occlusion or optic nerve ischemia.
Visual loss from these causes is considered irreversible after 100 minutes, highlighting the need for prompt recognition and management.
Ectropion, an outward turning of the eyelid margin, can occur after blepharoplasty.
This can be due to factors like excessive skin resection, scar contracture, cicatricial adhesion to the orbital septum, or orbicularis oculi muscle dystonia, contraction of the capsulopalpebral fascia, disinsertion of the lateral canthus, or midfacial descent. Patients with pre-existing lower eyelid laxity, they are at increased risk.
Early management of ectropion includes conservative measures like eyelid taping, frost sutures, massage, or steroid injections. Later management, if conservative measures fail, may involve surgical correction.
Leucophthalmos, an inability to completely close the eyelids, can also occur after blepharoplasty, usually due to excessive skin resection, or scar contracture. Persistent leg ophthalmos may require a skin graft.
Dry eye syndrome is another potential complication. Particularly in patients with pre-existing dry eyes, it's crucial to assess for dry eye symptoms preoperatively and manage them appropriately.
Corneal injury can occur during blepharoplasty. Fluorescein staining should be used to assess for any corneal abrasions.
Diplopia, or double vision, can occur due to injury to the extraocular muscles. Diplopia after blepharoplasty usually resolves spontaneously, but may require corrective muscle surgery in some cases.
Ptosis can sometimes become apparent after blepharoplasty, even if it wasn't evident preoperatively.
The A-frame deformity, a specific type of upper eyelid deformity, can occur after blepharoplasty. It's characterized by a peaked or tent-like appearance of the supratarsal crease caused by over-resection of the central and nasal fat pads.
So to wrap up this deep dive on eyelid anatomy, remember that a strong foundation in this area is paramount for achieving optimal results in blepharoplasty and managing its potential complications.
We've covered a lot of ground today, from the basic anatomy of the eyelid to the intricacies of surgical techniques and potential complications.
Remember, precise surgical techniques and a thorough understanding of the individual patient's anatomy and aesthetic goals, those are crucial for successful outcomes.
This deep dive has equipped you with a comprehensive understanding of eyelid anatomy, laying the groundwork for your FRCS class exam preparation. Best of luck with your exam.